Hi, this is Chapter 5, Mental Status Assessment. The mental status is a person's emotional and cognitive functioning. Optimal functioning aims towards simultaneous life satisfaction in work, caring relationships, and within itself. So you have to have those balances, and that's what most people are trying to achieve. They're trying to be satisfied with their life. They want to have optimal functioning and that kind of and feel good about themselves, and that's more of emotional type, as well as the cognitive, like um how a person may take in information, or how a person is living. So usually mental status strikes a balance between good and bad days, and it allows a person to function socially as well as occupationally. And mental status is usually pretty much relative, and it's pretty ongoing because people have what they call good days and people have bad days, and we all have days when we feel anxious or depressed. Stress surrounding a traumatic life event, like if a person dies or if there's a serious illness in a person's life, that may tip the balance, and that may cause a person to feel kind of not mentally with it at that point, because they'll be, in a in a grieving mode or a loss mode. So that's very, very important. And uh, as far as like mental disorders and that type of thing, a mental disorder is a little bit different. It is a significant behavior or psychological pattern, and it's associated with the following: people being in distress over a painful symptom, um, maybe a person having a disability or impaired functioning, significant risk of pain, disability, or death, or loss of freedom. All of that can, you know, uh, can affect a person's mental um, functioning. For example, major depressions has feelings that are unrelated or including delusional, or a person could be suicidal, or a person could have feelings of low self-esteem or worthlessness or loss of ability to function. So all of those type of things, they can really truly, go together. When you think about a person having some type of mental disorder. Mental status, structure, and function. For instance, example, and this is really good to know the difference. A person can have an organic disorder due to brain disease of unknown specific organic or origin, such as delirium or dementia. And it's really important to know what the difference is between delirium and dementia, or a person having alcohol or drug intoxication and withdrawal. If a person has delirium, brain disease, for instance, of a known a lot of times specific organic cause. So that's what when a person has an organic cause or brain disease that's known, they call it delirium. Where, for instance, when a person has alcohol or drug intoxication and withdrawal, um, you'll hear people talk about people when they're getting off of alcohol, they'll call it delirium tremors. Delirium tremors or DTs. See, DTs, when you hear a person say that, that's what they're talking about. They're talking about delirium tremors when they're um, coming off of some type of alcohol. And then you have things that have a more of organic or etiology, like an anxiety disorder or a schizophrenia or something of that case. When you look at those, you put them into the psychiatric mental disorder, um, and mental status assessment documents whether or not like a person has a dysfunctions, and it determines how that particular dysfunction affects a occur as far as a person's everyday life, so that's like important to know. So know that a lot of times when you think about delirium and dementia, usually delirium is something that comes on and it's usually a short term thing, just like, and it's something that people can generally get past. But a lot of times, dementia, it's like an ongoing thing. It doesn't come on people. If you'll see a gradual, oh, I'm sorry, excuse me, like a gradual change in that person's behavior. So you want to define a person's mental status. You've been doing assessments for the last few days, and you've been doing, I mean, few weeks, and you've been doing assessments, and you have been asking people various questions on during your assessments, and you've been asking them about their level of consciousness and that type of thing. Um, so we're going to explain. We got about 10 different things that I want to speak on. So, for instance, when you're assessing a person's mental status, you're worried about things like consciousness or the person aware of their existence, feelings and thoughts in their environment. That's whether or not they're conscious. That's the reason why a lot of times you can say stuff like they're alert or they're in stupor or they could be in a coma. That's conscious. Language. The person having the ability to communicate one's thoughts and feelings. Okay, mood and affect. Both of these deal with prevailing feelings. Like, for instance, affect is AFFECT, is a temporary expression of feelings or how the person, their state of mind is. And the mood is more durable, it's more a prolonged display of feelings that color the whole emotional life. So a person could be in a really bad mood, and that could show through maybe their affect. You see, some people or they may have a frown, or they may be withdrawn. That's their affect. But their mood is actually that, like, I'm doing this because I feel some kind of way about something. I feel angry at this time. So I may be you know, I may be uncooperative in this level, or, I may uh, have a stern affect or whatever. So, but if I'm in a great mood, and you may look at me and say they appear to be in a good mood because they have a pleasant affect. They're smiling, that's the difference between it. Orientation, we already know about that, able to name a person, place, and time. We usually say a person is oriented times three, etc., etc. Um, their attention. That is their ability to concentrate on what's going on in front of them, their ability to focus on what's going on without being distracted by whatever external stimuli is coming into play. Thirdly, you may want to assess their memory. Um, Recent memory is the ability to evoke day-to-day events. Remote memory brings up years worth of experiences. And that's what I was saying, that a lot of time you'll catch elderly people, and elderly people tend to have horrible recent memory, like, where did I put that thing? But they can tell you for sure what happened in 1962, or something like that. And you would be able to, like, really verify that. Then you think about how people think, like, for instance, their abstract reasoning. Um, Abstract is when you are going in deeper and finding a deeper meaning of something beyond the what's concrete, or what's literal, like, so you have an ability to look into things, and you may see something concrete going on, but you may know that that's not really what that is. Maybe a person is using a defense mechanism, or maybe the reason why they are not able to get their meds is going something that's a little bit deeper there. Maybe um, they have 10 kids to feed at home, so you're going into the the fact that a person may have certain behaviors or characteristics, and you're taking them a little bit further. Thought process is basically the way a person thinks about something. It's um, the what we would consider whether or not their thought process is logical or not. Thought content is, and the actual content is what the person thinks, um, and how they're able to put those particular beliefs or whatever into words. And then perceptions is an awareness of objects, awareness of something through the five senses. You get into a lot of that when you do some of your cranial nerve tests. And it also goes along with a person could be mentally ill, and they could be delusional, and they could be thinking that everybody's out to get them. They could be paranoid. So perceptions, but just because a person has a perception, always remember that that particular perception is their perception, and it's really real to them. But that doesn't mean that you go along with their perceptions. You always, always, always make sure that you correct them, but not in a demeaning way. You may tell somebody and they may be like, well, it's um 1929, and then you may say, well, actually it's um November 9th or something like that, 2020. And you'll see sometimes some people when you do that and they'll be like, really? Oh, okay, like that. So always, if you have a person and that person is not displaying the correct behavior, always think about correcting, but don't do it in a demeaning way. Just always stick on the truth, when you're dealing with people. So as far as developmental wise, infants and children, it's really, really difficult when you're talking about children uh, to separate and trace development of just one aspect of their mental status, because all of their aspects are kind of like interdependent on each other. So they're really rudimentary. And so, um, like for instance, consciousness usually develops with as the child learns and they're able to separate objects from the environment. And so they can also trace language development, like uh, the differentiation between crying and them maybe cooing, Um, as far as them using language as a terms of like a social tool, they really truly don't get there where it's really good like that until they're about 4 to 5 years old. And that's when you find them where they're starting to socialize with other children and that type of thing like that. Um, so as they go through school, as they develop, you have to look at those type of things. Um, Abstract thinking, when you consider like, okay, something being hypothetical or how you're going to react to a certain thing, usually develops between ages 12 and 15. Although some adolescents, they really never achieve it. I mean, some of them are kind of really out there. So I mean, there's childhood mental disorders. Of course, you know about children can have ADHD, um, uh, 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 oppositional disorders, autistic order disorders, anxiety or conduct disorder. They can get into alcohol, cigarettes, all type of little things which can impact their development. And another thing, a really important thing to look for when you talk about when you start going into the adolescent phase is interactions and different things that may even cause thoughts of suicide, because that's like a very important thing. Um, when you look at aging adults, you really have more potential for losses. Older adulthood contains more potential for losses. So, recent memory, like I told you, um, requires some processing. You might want to do like what they call 24-hour diet recall, where they name new people they've come into contact with. because that decreases as they age. Sensory perception and that type of thing, as far as their development is. They may have apathy, more social apathy, meaning like look like they don't really care, but they do. But a lot of times, what tends to happen is there becomes somewhat some frustration as they realize as they're getting older that they're starting to have more loss, like disability, disorientation, depression, chronic diseases such as heart failure, cancer, diabetes, and osteoporosis, and fear of loss of life. So, and their loved ones and all of that type of thing. So that is probably a big thing when you talk about in terms of people as they get older. Components of the mental status examination. Well, a full mental status examination is basically just a systematic check of emotional and cognitive functioning. Um, Keep in mind, when you're doing a health assessment interview, especially on an older person, keep in mind the four main headings of mental status assessment. And this is something that'll definitely be probably on a test, that ABCT. ABCT is basically the four main healings of a mental status assessment. A, which is appearance. B, which is behavior. C is cognition. And then T is thought process. So when you're doing a mental status examination, you want to make sure that you're assessing all of those type of things. You want to assess their appearance. You want to assess how that person looks. Um, when you look at their appearance, you want to look at their posture. Is it erect or do they look relaxed? Do they look coordinated? How is their dress? All of those type of things, or things that cue you in. Their grooming and their hygiene. You know, do they look disheveled like they don't really care or whatever? Do they have tattoos? Do are they deliberately like in fashion and that type of thing? You want to put all the things together when you're looking at a person in that form. Behavior, level of consciousness. Level of consciousness, right? We talked about the awake, alert, and aware. Whether or not their affect or their facial expressions, what's going on with their facials? Are they flat? Are they lethargic and drowsy? Are they confused? How is their speech? Is their speech clear? You can always ask a person directly, how do you feel today? And they may say great. And you may think, okay, I kind of asked them a closed ended question, but you can always say, how do you usually feel? To try to get more into it. Then you're looking at their C part, which is the cognition. Within cognition, you want to know, do they have an attention span? How is their recent memory? You may want them to do the 24-hour diet recall. What have you eaten within the last 24 hours? How is their remote memory? And I told you that about older people, that can tell you historic events. Then there's what they call the four unrelated word test. I remember President Trump was saying that they gave him that. And basically, what you usually do when you do the four unrelated words test, you tell them four words. You might say black, rose, carrot, foot. Black rose, carrot, foot. And then you go on and you do the examination. You tell them to do it. You start doing other stuff. And then about 5 minutes later, you'll ask them, do they remember the four words that you told them earlier? And that can give you an idea. And if anybody is younger than the age of 60, they say that usually that person should read you should remember at least three of the four words. Okay, so that's the way you give when you're trying to figure out if they have the ability to learn going forward or retain things going forward. Okay. So integrating mental status examination into the health history interview is usually sufficient, you know, for um, for most people. But like for instance, like let's say you did that four unrelated words, and the person only was able to recall one word, or they was unable to recall any of the words, you would definitely be thinking about potentially some type of dementia or something that was, or something else of, that particular or that sort. So you got you will collect ample data to assess mental health strengths and coping skills and to screen for any dysfunction. I'm going to tell you guys that it's really, really difficult to do that for the initial one because for some people, they're very great at covering up um, those type of deficits. But you can try all types of things. Word comprehension, you can point to things and have them name those type of things. And can they read any available print? And you got to keep in mind now about literacy. Like you got to keep in mind you wouldn't ask someone that speaks Spanish to read something in English. You wouldn't ask somebody with maybe they got a first grade or they're illiterate, education to read a part of a novel. You have to be careful, and that's all a part of learning about people and whether or not they're able to compose a sentence or write a sentence. All of those type of things is necessary when you're doing a mental status evaluation. And you're probably wondering, well, why is this even necessary? Patients who initial screening suggests an anxiety disorder or depression. That's why it's pretty necessary. Any behavioral changes such as memory loss, inappropriate social interaction, maybe they're doing something inappropriate, brain lesions. Maybe a person has a trauma, a tumor, had a CVA or stroke, aphasia, which is inability to speak, secondary to brain damage, and any symptoms of a psychiatric or mental illness, especially if it happened all at once. It was an acute onset. So I did introduce the word aphasia, APHASIA. That is different from the word dysphagia, which is the inability to swallow. Dys, inability to swallow, but is inability to speak. Okay? And that's something that you should be aware of. Note that these factors from the health history that could affect interpretation of findings. Okay? So, if there's things going, there could be certain things going on with that individual which could, um, affect what you're finding as far as, um, or make your testing off or not quite accurate. If a person has health problems such as alcoholism or chronic renal disease or something, and maybe those things aren't in order, or maybe they, or still dealing with it and don't have them stable, it could affect their mental status. Maybe if a person's on a medication and that particular medication makes them confused or depressed. Educational and behavioral level. Note that factor is normal baseline and do not expect performance on mental status exam to exceed it. So you have to know that when you're giving a person a mental status exam or a mini mental status exam, don't overdo a person. Don't give somebody that's a third grade mentality something that's for a 10th grade, you know, or take into mind a person's um, ethnicity or how they may communicate in their society when you're given certain exams and the way that you're asking particular questions and responses, indicating stress and social interactions. You want to know about sleep habits and any type of drug or alcohol use because those type of things can throw a exam off. Okay, so what you're looking at is you're looking at various type of examinations. Um, they have what they call the mini mental status examination, and you'll see it as MMSE. Um, but you have to be really careful with that with people who have lower education, and because it has like 11 questions and it only takes about 5 or 10 minutes to administer. It's useful for both initial and to see if a person's status is getting worse as you're going on. The maximum score on a mental status exam is something like 27 out of 30. And anybody that scores above 24 to 30, they have no cognitive impairment. So that's what that is. Then for children, they have what they call the Denver 2 screening test. And it kind of does um, developmental delays, uh, and that type of thing. and it is set up for like to identify like if a kid has a developmental or behavioral uh language, cognitive or psychosocial. um and actually the test is quite a long test because it has like 125 different items, and I'm assuming that they will give them to them as they go along. I mean, I don't think that they would, because it seemed like the cognitive level would, I mean, some children don't have very much, you know, attention span wise. So they have a table in your book where it talks about childhood mental disorders. So no little different things. Like they even have ADHD questionnaires. They have oppositional defiant disorder. I know my son in his career, because I told you he's a behavioral analyst and he works from very young kids up to about 21. Yeah, with and they have an autistic disorders, anxiety. Some of them have social phobia, um, and that type of thing. So it's important to know a history, know what's kind of going on, because a lot of times with children, stuff can be really, really, really a double-edged sword with them. I mean, it's like really hard. So you're getting all this objective behavior, which objective mean that you're looking to. Of course, you're going to get subjective what the patient tells you, but appearance, behavior, how much they comprehend, how much what their thought process of. Okay, so you want to see whether or not their posture is erect in position and relaxed, their body movements, are they coordinated, are they voluntary, are they deliberate, are they smooth and even, the dress, we talked about that, is it appropriate for the setting, season, age, gender, and social group. Uh, so the grooming and the hygiene, is the person, is it clean and well groomed, or their hair, is it neat and clean? Use care when you interpret clothing and that kind of stuff, because like I said earlier, some people, they fashion stuff, and it just may not be your taste, but it may be. But you can tell if a person is groomed. Okay, you can tell whether or not a person is well groomed or not. Level of person, level of consciousness. Oh yeah, okay. So we went over the grooming. Sorry. Level of consciousness. We already talked about whether or not the person is awake and that type of thing. Facial expressions, if they and they maybe have to do with cultural things because different people act differently. Okay. So speech, judge the quality of speech, noting that person makes sounds effortless and shares conversations appropriately. Okay. Their ability to articulate certain words and use, make sure it's understandable. And it may not be just understandable because the fact that, oh, it's a cultural thing. I'm talking about if they are like actively engaging and they might use certain words, or they may think about what they're saying. They're not just like rattling on. And then we talked about the mood and the affect part. So we talked about orientation, attention span. If a person's anxious, fatigued, or intoxicated, so if they're anxious, if they're tired, or if they're intoxicated, that attention span is usually off. They tend to wander. Um, I told you a good way to check for recent memory would be to assess the 24-hour diet recall, or by asking time person arrived at agency. Ask questions that you can corroborate. you know. As far as remote memory, we already talked about assessing that, and we talked about how a person, um, depending on who they are. Remote memory is lost when cortical storage area for that memory is damaged, such as in Alzheimer's, dementia, or any disease that damages cerebral cortex. Four unrelated words test right here. I have it. It's a sensitive, valid, and I'm repeating it because I want you guys to remember these. These are important. Requires more effort than recall because you pick those four words and they may be totally unrelated. Then you can go about doing what you're doing with the cast and then come back 5, 10, or 30 minutes later and ask them, do they recall any of the words? And we told you if you're under the age of 60, they should be able to get 3 or 4 words. What is their judgment? Is a person, when you talk about mental status, you guys, oh my gosh, is the person just out there doing all kind of stuff like what we usually call off the chain? And they're acting recklessly and they're not taking into consideration like what the consequences would be um for their particular actions. Test their judgment. See if the person has any violent capacity, or if a person is acting in response to hallucinations. Note whether a person has any long plans in the future about their job, and do that stuff seem like it's unrealistic? You got a person and that person uh is barely making it through high school. I mean, when I say barely, they barely making it through, guys. They got a D average. They're taking special classes, and then they tell you that they're going to be a brain surgeon. So it's like that type of thing. Maybe you may need to look into it and see, well, what would you do if you wasn't a brain surgeon? What would you thoughts? But what some things happen for people. Some don't tell them, well, oh no, you're so dumb, you can't be a brain surgeon. No, you just ask them, so do you have more than one plan in case that plan don't work out? Because I know a lot of people, they have more than one or two, three different things that they might decide on doing. You might get into school and say, well, this is not for me, you know. So you want to ask about that. You want to ask about whether or not they have any type of obligations, whether or not they have any type of regimens that they use as far as their health care, or they attending health care. So you got thought processes, thought content, and perceptions. We talked about that. A thought process is logical, goal directed, coherent. You understand it and it's relevant. That's how they should be, but it's not always like that. Thought content, what their thoughts are about, should be consistent and logical. It shouldn't be, yeah, what I'm gonna do is see, it's this little spaceship up there, and they got this spaceship, and as soon as I get my money right, you know, that's where I'm gonna go live in this spaceship, and I mean, you'll hear that kind of stuff. And perceptions, everybody's out to get me. Everybody. I can't even use my phone because I know they're spying on me. Well, exactly what do you feel that they're spying on you about? Everything, everything. They want to know what I'm eating and everything. Like it would take for you to have to hear a person, talk about that type of thing to know what you're talking about when you know that they have delusional ideas. Okay, so before we do that, I want to just make sure you guys that you are aware of various things like a person's alertness. Okay, because there is um 5 different alert, and I want y'all to make sure you keep this in mind. A person could be alert, they could be lethargic, they could be obtunded, which is they're difficult to arouse, and when you arouse them, they act kind of confused. They could be in a stupor or a coma. They could be in a coma, or they could be like totally delirious. When you talk about in terms of these are things when you talk about a person's level of consciousness. When we talk about people having speech disorder, I want y'all to know about the different speech disorders. Um, I don't know if I don't think I mentioned it, but I'm gonna mention it because I want you to know it because it's very important. There is a table for speech disorders, okay? And I want you to know about the 3 different words. There's dysphonia, dysphonia, and that's when a person has difficulty or discomfort when they're talking. There's dysarthria, dysarthria, and that's when they have distorted speech, when they have difficulty articulating. Remember, I was saying that my mom had some distorted speech, and that let us know that was part of, and with me being a nurse too, of her hearing. I'm watching her behavior. And then when she has on her hearing aid, everything is perfectly copacetic. That's the kind of thing that I'm talking about. Um, um, uh, Aphasia and true. That's just like a true language disturbance. Um, they don't comprehend. They can't process. Um, the speech, and uh, they can't comprehend it or they can't process it. And a lot of times that's based on uh, uh, brain damage. So you have types of aphasia with language. You have global aphasia, Broca aphasia, and Wernicke aphasia. Listen, Broca aphasia is expressive aphasia. Broca. And all of this stuff that I'm saying to you guys is in your book. But broca aphasia is expressive aphasia. Wernicke, Wernicke, aphasia is receptive aphasia. So, broca is expressive. And I remember that because I always remember that the B and then there's the E, so that's expressive. B-E is at the beginning. And then Wernicke aphasia is the receptive, W-R. They're at the end of the alphabet. That's how I remember them. Receptive means that it's the opposite. They can use some words and their speech is kind of effortless and whatever, but they're not what they're receiving, the sounds and things they hearing, they have an inability to relate um these words and comprehend, you know. They usually have a great urge to speak, but it's like a repetition type reading and writing. All of that kind of stuff is kind of impaired. So yeah, they usually have some type of uh so expressive, and then you have what they call global, and that is when they have some type of lesion in both the anterior and posterior language areas. Because like for Broca, when they have expressive, their motor and speech cortex, which is the Broca area, is damaged. For the Wernicke, their language area in the auditory cortex is damaged, which is the Wernicke area. So Broca is ability to express. Wernicke is um, the inability to receive. And then global is almost like a combination of both of them. Okay, so remember your speech disorders: dysphonia, dysarthria, and aphasia. What that means, I've described it. Types of aphasia will go into global aphasia, Broca aphasia, and Wernicke aphasia. Okay, then there is also an area where we've talked about all of these things, uh, but there's more words where you can um, describe a person's mood and affect. Okay, uh, so and they'll say it's a mood, and then uh, affect abnormality. So a person can have a flat, they can have depression, they can have what they call depersonalization, they can have elation, euphoria, anxiety, fear, irritability, rage, ambivalence, labile, which means that a person's emotions are just all over the place, and then inappropriate. So know about those type of things. Know about those type of things. And then there is specific anxiety disorders, like a person can have a panic attack, a person can have agoraphobia, which is agoraphobia. I'm sorry, you guys. Um, um, like they have a fear of like being out in the open, agoraphobia. They can have social anxiety disorder, specific phobias of different things like, oh, I'm scared to death and of dogs and spiders, or I'm scared of storms. And what I'm saying is these people are like very, very, you guys, very scared of these particular things. It's not like it's a dream or they putting on. They can have a generalized anxiety disorder. They could have obsessive compulsive, and that's when a person takes that stuff to a whole nother level when they have OCD. When they are so clean, it's just almost disgusting. For instance, like, you know what I'm saying? They'll do something over and over again. I told you guys to know the difference between delirium, dementia, and depression. Delirium, dementia, and depression. Delirium is acute, dementia is a chronic progressive loss, and depression is a long-term depressed mood. So there is a chart in your book, and what it does is it describes in chapter 5 the different attributes of delirium, dementia, and depression. I gave you a little bit of a example of a delirium, and remember I was telling y'all about DTs, and they have illusions and hallucinations and everything, and they could possibly die when you're trying to get them part. But dementia is impaired judgment and memory loss, and a lot of times it's like a warning sign that a person's coming down with Alzheimer's disease. And then depression, you get into things like the loneliness, the sadness, the despair, the suicide. And this stuff has happened like over and over and over and over again. Okay? So what you do is you have it's important, you guys, to screen people for things like you want to screen them for things like suicidal thoughts, suicidal thoughts. uh, when a person say that they are feeling really sad and hopeless, and when you could look at your checklist and you say, do you feel safe at home, you can go into that and stuff. Despair, agree, do you think that you may risk physical harm to himself or herself? You'll be surprised, because you know how some people say that suicide is like a cry for help. Well, you'll be surprised of how individuals will tell you. They will tell you, guys, that, hey, I'm feeling X, Y, and Z. Oh, yeah, I did try. You want to know if they have a plan? Do they do this? Because usually what happens is a lot of times if a person's been going through a lot and they've been really down and they've been feeling like really a lot of grief, and then all of a sudden, nothing changed, all of a sudden nothing with their life has changed necessarily to make things so much better. And then they say what they do is they start giving away prized things to family members or to whatever. And you be knowing, like, okay, they love this. You know what I'm saying? They really love this, but they gave it to their little brother that they always thought was. They said that sometimes that's because they've made up their mind and they've had and they have a plan. So that's something. So ask about general questions initially, like, do you feel like you want to hurt yourself? Do you have a plan to hurt yourself? How would you do it? what would happen if you were dead, how would other people react if you were dead. You want to get into that. And it's real difficult because you don't want to invade a person's privacy. But let me tell you something. As a healthcare person, if you could possibly get in there and you could possibly stop something from occurring and maybe get a person therapy or something, and maybe uh because some people it's just a crowd for help, and some people they may complete it but really didn't want to complete it. So it's just, to me, suicide, that's a very, very powerful, very, very depressing, just, oh my God, they need mental health professional right away. Okay, so development of a care of aging adults, it's usually common in older people. It's usually misdiagnosed. A lot of times, a person can have a urinary tract infection, an older person, and they could get confused. And as soon as the urinary tract infection is cleared up, their mind is clear. You know that they're going to have some lapses of memory, but they're going to be little things, just like we forget things every now and then. So you got to know that a third to one half of older adults are admitted to acute care medical services showing varying degrees of confusion already present. In the community, about 5% of adults over 65 and almost 20% of those over 75 have some degree of clinically detectable impaired cognitive function. My parents are in their 80s. I figure they do pretty doggone good for them to be in their 80s, but they do have a little bit of, they'll forget little things and stuff like that. They got calendars, everything, stuff everywhere to remind them of this. I'll call and I'll be like, oh, we got to do blue, blue. Oh, yeah, yeah, that's right. I forgot about that. That's a normal thing. And the best thing as a nurse you can do is keep orienting them. Keep orienting them. Don't let people, because I know sometimes people don't want people to feel bad, and what they'll do is they'll let them go on with that type of behavior, knowing that that is inappropriate. So you correct them lovingly, and but at the same time, you're constantly orienting them. So you're going to check all their senses, vision and hearing, all of those stuff, you guys, plays a big role in a person's mental status, or whether or not they're confused. When older people cannot hear your questions, they may test worse than they actually are. For instance, when they can't hear. And that's a big thing. I told you my mother was faking the funk. And I don't know why people do that. I don't know why they won't just admit. I guess it's just the reckoning with the fact that I really can't hear that good. But when they get that hearing aid in, and you can't even see the suckers nowadays, um, and they get to doing things and it's back, and all of a sudden they stop falling, all of a sudden they stop talking with a garbled sound, all of a sudden their voice is a normal tone, they're not shouting. It's like heaven, and a lot of them will tell you that. But initially you may have some fight back, about that. And I don't know why, when we went and got my mom's hearing done and everything, the physician there was saying that they all do the same thing. They read lips, they cheat, they do everything. And he said he don't know why it's so hard for them to realize that they can help that and improve their quality of life. So, and like here, it says a group of older people with psychiatric mental illness tested significantly better when they wore hearing aids. So, yeah. So, know about aging people. You know how I feel about aging adults and cognitive and knowing the tests that I told y'all about, the recall, and the testing their acute memory and their short memory, the unrelated words, the four unrelated words test. Um, you just got to know. We've been doing that all along. Like I hear it mentioned again about the four unrelated tests and uh, waiting 10. So here, subjective appearance, and it's just basically a no score on many mental status examination is 28. Oh, that's good because remember we told you it goes up to 30 and anything below 24, you're looking at some type of deficit. Okay. I would like to say to you guys, I'm gonna click back on that screen, but is there are very different ways and very different thought processes. I want to speak briefly about some things that are thought processes because I want to get into things that people they're abnormal type thought processes. You have a chart and it has different types of thought process abnormalities, like blocking. Blocking is when they have a interruption in the chain of thought where they'll say, forgot what I was going to say. Confabulation, where they basically fabricate, they fill in gaps, they lying. They'll be telling you a story about, yeah, I went down the hall and ambulated and got my own water. You be knowing good and well they ain't did that. Confabulation. Neologism is when they use these words that they didn't invent it. Like for instance, they'll say, oh, I'll have to turn on my thinkulator. Well, what's a thinkulator? That's a neologism. Circumlocution. That is when a lot of people do that. Substituting a phrase when they, instead of like, they might call something a thingamajiggy. You know that thingamajiggy we was using, like, yeah, that's circumlocution. Circumstantiality. And that's when they give you all these unnecessary details, like they'll be talking about one particular thing and then they'll start saying, yeah, when I was 20 and I had my, and this would be somebody 68, and I had my surgery and my aunt was like, that day she took me to the store and she did blah blah blah, and you'll be sitting there looking like, okay, let's get back to the real you know thing. Oh yeah, my aunt, she had real bad arthritis, but you talking about them. That's when they do that. And then loosening associations, shifting one topic to an unrelated topic, and they don't even seem to know that the topics are not relatable. You know, like they'll be talking about uh somebody being mad at them and then start talking about when I was a little boy, I saw I don't know, Lassie on TV, or I saw the Lone Ranger, and you be just like, okay, that's not related to what we're talking about. Um, Flight of Ideas is when a person, like, they do this kind of stuff. You may say, okay, here's your pill to take, and they'll say, take this pill. Mm, the pill is blue. I feel blue. The sky is blue. His dress is blue, like that. That's like fly the ideas. Word salad is when a person has incoherent mixture of words and phrases. Uh, and basically, that's when they're just saying a bunch of little words that don't mean nothing. They might be ugly, and they might say ugly, blue, base 10, uh, fish, um, stoplight, will do. And you be like, what? That's word salad. Preservation is when they repeat the things. They'll be like, I'm going to lock the door. And when I leave for work, I always lock the door. When I take my dog out, I lock the door. That's preservation. And then echolalia is just when they are, it's like a mocking. It, like, for instance, if you say, I want you to make your bed, and they'll say, make your bed, make your bed, make your bed, like that. And then clanging is when they're rhyming. They're like, they may say, my feet are hot, hot, cot, rot, bot, top, like that. Okay. Then you have uh, thought content abnormalities like phobias. We talked about that's an irrational fear. Hypochondriasis is when a person always feels that something is more. They're going to always think that when they are feeling bad, it's got to be the worst. Oh, I strained my back. Oh, I must have lung cancer. Okay, obsession is um when they have like an unwanted thought or impulse. You know, when a compulsion is when a person has to do something repetitively, and a delusion is a fixed false belief or something that's irrational. So they could be grandiose delusional, like where they think they a famous person and they think they the best thing since sliced pie, or they could be persecutory, which means that they are like these people are out to get me. This person is trying to poison me. My wife is she putting stuff in my food. And then you got hallucinations, which are perception abnormalities. So you got sensory perceptions, which are visual, like you think you've seen a ghost or you heard something. And then misperception, which is an illusion where there's really an actual sense, but that thing is there. Like you might see the chair and the chair is really there, but you might see, uh, I don't know, bugs, bunnies on the chair, but the chair is really there. When you hallucinating, the stuff is really not there. when you have an illusion, it's there, but you're thinking something else about the thing that's there that's not. And then they have what they call eating disorders. So as you can see, you guys, there's a lot of different abnormalities. And when I do the testing, I'll be real particular on what I want you guys to try to remember. But it's really worth it to I don't know, like really get into, like, read on it and stuff. It's and you'll learn a lot more about it when you turn into psych. I'm just mentioning. And then you have characteristics of eating problems like anorexia nervosa, when they have intense fear of weight gain and they don't eat. Um, and then you have bulimia, where they binge and then they vomit out stuff. And then you have binge eating, where they binge, in order to, and they get depressed and embarrassed, or whatever. Like sometimes a person could be depressed and then they're binge eating because they're depressed. Where bulimia is strictly on the weight thing and the body image thing, just like anorexia. Bulimics, they wanna eat something and they'll binge and then they'll take a whole pack of laxatives, or they'll binge, you know what I'm saying, by vomiting. But anorexia, these people, they may binge and stuff too, but it's not consistent. With them, they just ain't trying to really truly eat at all, you know. So here's a copy of a little note, and I think that's basically, you guys, the end of my lecture. I told y'all about all the little different childhood mental disorders and that type of thing. And there's a little summary checklist at the end of your book. And know the characteristic of the ADHD and the autism and the eating disorders and oppositional defiant disorder. My son, he take care of all these people. I mean, and it's just like a trip. So have a good one, and that's the end of mental status assessment.